truly.
Free Fridays. Welcome everybody to Falls Free Fridays. We're so glad you're here. Thank you for joining us this afternoon. We've had a great time recording these sessions and pushing them out, and you will have access to that recording after this session is taped. Many thanks to the Department of Public Health, Injury Prevention, to Emory iPrice, and to Shepherd Center and our library partners. This is a joint effort, and we are so glad that you're here. A couple of housekeeping items. After our presentation today, we will have one more presentation on living your best life. That is next Friday at 10 a.m. And we have two fabulous speakers here today. I'm going to go ahead and read their bios. First up, from Complex Concussion Clinic at Shepherd Center, is Dr. Kimnisha Pollard, and she is the ABI Post-Acute Physical Therapy Manager for Shepherd Center at Pathways, Share Military Initiative, and the Complex Concussion Clinic. She received her Doctor of Physical Therapy from Western University in California in 2012, her Master's in Physical Therapy from the Mayo School of Health-Related Sciences in Rochester in 2001, and her Bachelor of Science from Morningside College in Iowa in 1999. Dr. Pollard is an APTA board-certified clinical specialist in neurology and has over 22 years clinical experience in the areas of orthopedics and neurologic physical therapy. She has worked at Shepherd Center in the subspecialty of acquired brain injury for over 12 years. In her career, she has mentored extensively, taught courses, and provided guest lectures in the area of vestibular rehabilitation at Georgia State University. She has worked as a mentor in the neuro residency program at Shepherd. She has been active in the Traumatic Brain Injury Model Systems Initiative, assisting in creating content and presenting in the area of sexuality and intimacy in brain injury. Dr. Pollard is an active member of the American Physical Therapy Association, APTA Academy of Neurologic Physical Therapy in the APTA and APTA Georgia chapter. Her overall goal in life is to enhance the quality of life for her clients and patients and to help them to be as active, safe, and mobile as possible. We are thrilled to have Dr. Pollard with us today, and she will be presenting first, and then we will take questions after her presentation. But I'd like to introduce our second speaker, someone I have worked extensively with through over a decade now, and that's our own Liz Head. Liz's area of expertise is aging and injury prevention. She earned her master's degree in public health from Georgia State University. She has worked in public health for over 17 years. I think we found it was 18 this morning. As Deputy Director for the Injury Prevention Program at the Georgia Department of Public Health, Liz coordinates the B-Scene Project for Georgia, funded by the CDC. This project aims to incorporate public health into dementia, including Alzheimer's work happening in the state. In addition, she manages highway safety grants and staff and the injury prevention staff working on projects across the lifespan. She has worked with national, state, and local partners on a variety of injury topics, including fire prevention, drowning prevention, and fall prevention. Other professional experiences include research on bathroom injuries for children and adults, evaluation of fire safety education programs, and facilitation of coalition activities for older adult driver safety and fall prevention. Liz spends her free time enjoying quality time with her family. We are thrilled to have them both here. It's a very exciting collaboration. I'm Emma Harrington from Shepherd Center. I run the prevention program there, and this is exciting for me because we have an expert in our field at Shepherd Center in complex concussion, in our complex concussion clinic, doing this collaboration with a longtime partner of Shepherd Center in Liz Head with the Department of Public Health. So without further ado, I will be monitoring the chat as we go. Please feel free to pop questions in there at any time. And Dr. Pollard, it's all yours.
Thank you, Emma. Hi, everyone. So my name, as Emma said, is Kimnisha Pollard. I am representing Shepherd Center for the Complex Concussion Clinic. I am currently the ABI Post-Acute Physical Therapy Manager at Pathways, Share, and CCC. So we're just going to talk a little bit today about comprehensive concussion care and treatment. At CCC, we provide a holistic approach to individualized treatment. Within this clinic, we have 10 different specialties under one roof, and I'll talk a little bit about that a little bit later. We do provide options for telehealth in addition to in-person treatment. We provide regular evaluations to measure progress to goals, and we provide unique research-based comprehensive evaluation and treatment. So, who we are and who do we see? Complex Concussion Clinic brings together interdisciplinary teams of specialists to address complications and provide a streamlined path to full recovery. We are an outpatient mild traumatic brain injury program. We consist of a comprehensive interdisciplinary team, including medical providers, and our medical providers specialize in neurology as well as PM&R. Behavioral health providers specializing in neuropsychology, sport and rehab psychology, and counseling, athletic training, physical therapy, occupational therapy, speech cognitive therapies, vocational counseling, and case management. We see clients that are 12 years and above and that have experienced a concussion typically within the past 6 months. Once our patient has been evaluated, our care team develops a treatment plan tailored to each patient specifically injured and need. So whatever their injury is very specific to what they need. These may include weekly visits to one or more of our therapy specialists for 8 to 12 weeks. The clinic streamlines care by providing interdisciplinary resources at a single location with state-of-the-art equipment and serves patients 12 and up who are experiencing symptoms from a concussion or mild brain injury. Like I mentioned earlier, treatment is completed in person or virtually, depending on patient needs or depending on the recommendation of the specialist. So what is a concussion? A concussion is a sudden blow to the head that causes a mild traumatic brain injury. Typically, concussions resolve within a few weeks as headaches and other symptoms subside. Patients can return to work, to school, or to athletic activities, often feeling capable as they did before their injury. However, some individuals may require care that falls beyond the scope of the primary care provider. In these scenarios, more complex rehab for concussions may be necessary. So just to give y'all some facts about concussions, according to the CDC, over 2.5 million traumatic brain injuries occur in the United States every year. And most of these are considered mild traumatic brain injuries or concussions. The actual number of concussions actually, though, may be higher because half of them go unreported. If you think about a lot of the kids or athletes, they may not be reported. Now, I feel like as time has gone and people have become more educated about concussions, it's gotten better, but still we have some out there that are probably not being reported. Falls, being struck by an object or motor vehicle accident are thought to be the most common causes of traumatic brain injuries in general. However, it's estimated that up to 3.8 million concussions occur in the United States during sports and recreational activities each year. I don't know about you guys, but that's a pretty big number of people that are affected by this. So quite significant and important to talk about. So what is a complex concussion? These are conditions that might be classified as a complex concussion. So it's a person that had a concussion within the last 6 months. They have a history of complications from concussions. They have had an abnormal imaging or testing. They've had prominent dizziness, imbalance, visual symptoms after a concussion. They have a history of headaches, migraine, anxiety, or depression, or they have a history of previous concussion. This is actually quite prevalent with people that we see, or other concerns that may affect this and may cause other issues. So common symptoms of a concussion. So there's so many different, symptoms that involve concussion. A lot of us, think about the physical symptoms, but there's so much more to that. And that's why it's important to get a whole team of people to evaluate and assess this. So physical symptoms, you may have dizziness, you might have headache, you might feel off balance. And if you can imagine, if you're feeling off balance, you're definitely more at risk for falls. You have sensitivity to light or noise, increased fatigue, and visual difficulties. So some sleep symptoms, they may have changes to sleep patterns, difficulty falling asleep, or even difficulty staying asleep. Emotional symptoms, increased irritability, feeling sad or down, feeling nervous or anxious, or might have mood swings. Some cognitive things to think about: they might have decreased attention, memory problems, slower thinking, and difficulty following directions. So typically with a concussion, you see that a lot of these symptoms should resolve within the first 7 to 10 days, um, but they can take up to 3 months to typically resolve. So why would someone seek care for a concussion? Like I said, usually concussions resolve within a few weeks as headaches and other symptoms subside. However, patients return to work, return to learning, driving, or physical activities. Sometimes they feel less capable than they did before their injury. And some individuals may require care that falls beyond the scope of a primary care provider. And these scenarios, that's where it's more important for them to seek care for complex rehab for the concussion. So a big part of what we do as Shepherd, we're not limited to just working with people in sports medicine. We pride ourselves on working with a wide variety of people in all stages of life. So like I said, that can go all the way down to your 12-year-olds, your adolescents, all the way up to maybe someone who's fallen, who's elderly. So a big range there. We strive to return patients to their full activity and performance level as quickly and as safely as possible. We seek the best outcome for each patient through evidence-based individualized interventions. We empower our patients through active rehab therapies early in the healing process to prevent long-term complications and to spark recovery. We also minimize the use of medications because sometimes medications can mask symptoms or they can cause side effects that slow progress. Our interdisciplinary team of specialists consult with families, employers, coaches, athletic trainers, and school officials to ensure safe return to pre-injury activities. We also develop and implement accommodations as needed to enable patient success. So we may say someone's okay to return to play or return to school, but again, putting in some accommodations to modify things to ensure that they have success with this. Complex concussions can be troubling for patients and medically challenging for frontline physicians. So our focused approach to care can significantly reduce recovery time and improve patient outcomes. So I'm going to see if this works here, y'all, just to kind of give you a little bit on what we have for equipment. This machine here is called the static Vertex force plate. I'm just going to play. Me as a PT, I'm like, oh gosh, I probably would have somebody behind guarding him, but it's just a video. The person's okay. But anyway, that's my little spiel. Right here is our BITS device here. As you can see, the patient is working on visual scanning, probably a little bit of reaction time as well. But this machine, the OTs use this a lot to work with vision. And down here is our Vertex. I don't have a video of this, but this is the force plate that moves. Okay, so it's like a virtual reality situation where you can do a lot of assessment and you can do treatment as well. So this helps with assessment and treatment of balance as well as vestibular impairments. Move on to the next one here. Okay, so this is just to kind of give you a little picture on how our team works together to get people back to different things. So as you can see, the top is return to learn, return to work, return to drive, and return to play. Within each box, it gives you an indication kind of what disciplines are prominent in doing those things. Although I say that with a grain of salt because there may be times where someone's trying to return to work where the PT has to help with the physical piece of it, right? It's not just the behavioral health, it's not just the cognitive piece, but it's the physical piece too, and vice versa. If you look at the return to play, if someone's having issues with cognition, if someone's having issues with memory, if they're having problems with attention, it's going to be very hard to return to play if they can't do all of that. So I say, you know, this has a list of primarily what disciplines work on these things, but it's all interchangeable is what I'm saying. We all work together depending on what the needs of the clients are. Moving on, so just to give you a little snippet on which each discipline does at our facility, behavioral health. So we provide individual psychotherapy as well as neuropsychological assessment, okay? So this is just a list. I won't read it all, but they provide psychological support, psychoeducation, sleep hygiene is huge in this patient population, emotional regulation, post-traumatic growth, complementary and alternative medicine, also comprehensive cognitive assessment and recommendations. They work along with the speech therapist very closely with really giving us the help that clients need from a cognitive standpoint and an emotional standpoint, behavioral standpoint, behavioral health, I should say, standpoint. So very, very important in our setting with behavioral health. Next is athletic training. So the athletic trainers work to do a lot of different things in our patient population. They help follow up with physician extender appointments for symptoms management, record reviews. They assist with procedures. They may help facilitate with getting lab draws done, although we have nursing in the building as well. They assist with concussion testing, and that includes ocular motor, cognitive reaction, and balance. They provide patient education. They assist with return to play and activity. They help with coordination of care as a whole, and they are a big piece of the research that we do at CCC as well. So physical therapy. We provide assessment of post-concussive symptoms. We conduct a problem-focused interview. We provide standardized questionnaires and testing to quantify symptoms. We assess balance, gait, vestibular function, exertional tolerance, and we examine the cervical spine to determine its relationship to dizziness or headaches. So with that, we provide individualized interventions from a PT standpoint. But again, it always goes back to coordination with the team to facilitate return to play. It could be return to school, it could be return to work. It's not just play, but we do a lot in other aspects as well to help the client get back to their normal function in life. So for speech therapy, speech therapists typically address cognitive symptoms such as memory, attention, decision-making, problem-solving, processing speed. They address communication challenges such as word finding and thought organization. So what do speech therapists do at CCC? So a lot of their activities may vary based on the patient's needs. They do specific activities like they research a calendar app to use as a memory tool, and they come up with a system for using it consistently. They create a daily routine or schedule, which is very, very important. I work not just in CCC, but I work at Pathways where it's more the moderate and severe traumatic brain injuries. And with TBI clients, structure is very, very important. So creating that structure and daily routine is important. They establish weekly goals. They check on progress and obstacles related to those goals. And they practice communication strategies to help focus and remember details during conversation, as well as organized thoughts. Next is occupational therapy. So the definition of OT is like, what do you need to do, want to do, or are you expected to do in your day-to-day life? They maximize life participation. So within OT evaluation, they develop occupational profiles. They help people with visual symptoms and sensitivity. And some of these things that they help out with is reading speed and accuracy, brain tolerance, sensitivity to tracking objects, movement in the environment, light, glare, and contrast. They work on instrumental activities of daily living, and there's a whole slew of what they do, and that's what ADL stands for, like the driving, the work. Can you go shopping? Can you take care of yourself on a daily basis? That's what OT primarily does. Moving on next. Sorry, my screen's a little bit delayed. Vocational counseling. So vocational counselors, they assist clients with crafting reasonable work accommodation requests. They help create return to work timelines in conjunction with other clinicians. They help clients with crafting, job board assistance, career interests, and inventory skills assessments. They help with education with SSI and SSDI benefits. And they often provide referrals to state vocational rehab agencies. So they're huge in our department as well with return to work. Case management is kind of, that's a discipline that kind of holds everybody together, honestly. They work to support all patients as needed. They manage any patient's needs or concerns with overall treatment plan. They facilitate weekly interdisciplinary team meetings with the MD and treatment team. They lead patient goal setting and/or family meetings, and they work collaboratively with the team and serve as a liaison between therapists and physicians, not only within the team, but they're the liaison. Like we have a lot of people who are workers' comp or have workers' comp as a peer source, have been hurt on the job. So they work along with external case managers as well with managing their care, making sure they're advocating for the client to get the services that they need based on the recommendations of the team. So just to give y'all a little bit more of what we do and some of the equipment, this is just another, I don't know if you can see my pointer, but the top one with the thing that looks like a VR, this is like VR, it's Vertec. That's where we do a lot of assessment for vestibular imbalance. And this right here is a rotary chair. It also does what we call vestibular function testing to really see exactly what's going on with the vestibular system. Also, we showed this a little bit earlier. This is the static part of the Vertec. This is another photo of the Vertec, the bits, and these are the VNG goggles. Again, it does a lot of the testing for vestibular system. In addition, we have, which is not pictured, a driving simulator that the OTs do to help people to return to drive. Just to also let you know, we have several research studies going on. One is called RO1 that is working on the vestibular impairment, one called Success, as well as Drive Safe. So not just one discipline, but it goes across different disciplines where our clinicians are involved in research. So just to give you a little plug and let you know how to access care at Complex Concussion Center, there's a phone number here that you all will be able to access where you call our access case manager. Also, there's a scheduling registration form along with insurance card. And once you supply those things, you'll be contacted and an appointment would be scheduled for you. So in conclusion, our overall goal at CCC is to provide holistic approach with individualized treatment for clients. It's an involvement of a multidisciplinary team to provide support and treatment for all aspects of health and well-being, not just one, but all. We provide evidence-based comprehensive eval and treatment. And the ultimate goal is to facilitate clients to return to school, drive, play, and normal function. So are there any questions?
Dr. Pollard, I don't see any questions in the chat. We'll give them just another minute. Oh, Liz, do you have a question?
I do actually. It's such a fascinating presentation. Thank you for the overview. When clients or patients start out, what's hardest for them to do versus what becomes easier over time?
Gosh, it just depends. You mean as far as like abilities and things that they have problems as far as with impairments?
Mm-hmm.
Just from my personal experience, I've seen, it depends on how bad the concussion is, right? I feel like just having a lot of input or stimulation sometimes becomes really overwhelming for people, you know? So I've seen it where it's been really severe, where you really have to dial it back. There are some times where I'm doing vestibular testing, which is a lot all in itself. You're making people feel dizzy. You're taking them out of their comfort zone. They have to completely trust you in order to go through with this testing, right? So usually you can get through a lot of that stuff in 1 or 2 days. I've seen where you really have to go slow. It might take 3 days or 4 days for them because they're so symptomatic. So I find initially, if they're really symptomatic, just taking things one thing at a time, and then you're able to push a little bit more, and they're able to tolerate more from a physical standpoint, or from the same thing with cognition. Like having someone do a full hour is sometimes it's too much. You know, they start to have more of the headache. They start to have the other symptoms, feeling dizzy, anxious, all of that combined. So doing little by little, and then you see when they're finally able to go back to doing their everyday tasks. It does happen, and it's awesome to see. Sorry, I hope that answered your question.
It does, yeah. It's fascinating. I feel their pain, and I don't even have a concussion, so I can't comprehend like how terrifying and overwhelming that would be.
Right.
Okay. Thank you so much. Wonderful presentation. Liz, you are up next as you're pulling your slides up. And if anyone has any other questions, please feel free to put them in the chat whenever you like. Okay, Liz.
Thank you, ma'am. Good afternoon, everyone. And I'm so honored and pleased to be able to do this partnership presentation with our friends at Shepherd Center. Such a phenomenal set of professionals doing work that's really making a difference in people's lives. What I really wanted to talk to everybody about today is, how do we talk about, as professionals, with our patients, with our clients, with the public, with the community, about really tough topics? And so we've had quite a bit of success leveraging fall prevention to talk about more stigmatizing topics. So we're going to dive into that a little bit today. And hopefully at the end of this, you'll have some resources that make sense for you and that you can use in the field. So the first thing we talk about, of course, is what does it mean to age? And please feel free to put in the chat if you have anything that comes to mind when you think of aging and old. I know my parents call it old timers, and that's just referring to aging. That has nothing to do with dementia or Alzheimer's disease. That's just what they call themselves. Getting older, getting grayer, getting slower, nothing really hugely positive, right? Which is a challenge, because there are a lot of positive things that can be had as we age, and that in and of itself becomes rather stigmatizing to get through, so you can focus in on whatever is happening physically or cognitively for whatever reason with an individual. So we want to take a moment and talk through those. And as we're talking about everything that we've discussed today, it's really important to consider this role of what is essentially ageism, and how it is that we can overcome that in our own language as we're talking to the community, and how we can work towards being person-centered. I really find that everything that our friends at Shepherd do is so person-centered. They're really taking that person and moving them forward to some level of function that is meaningful for that individual. The true definition of engagement, rather than just outreach and talking out or throwing some flyers at people, not literally throwing, but it's a really powerful model that Shepherd has, and that other service-based folks have, that we could really learn from as we're doing public health education. So this should look familiar to most folks. So a lot of the things that happen to us at age center around three topics, right? We're looking at changes to mobility, we're looking at changes to our vision, and we're looking at some changes to cognition. That second column there is the role of normal aging. So we expect to slow down, we expect to potentially have some lesser muscle strength, for our endurance to be reduced. Certainly in terms of vision, if you have had horrible vision like I have had my whole life, I'm not expecting a ton of changes. But for those that have enjoyed pretty quality vision throughout their life, as you age, you're going to start to notice that declining a bit. And certainly, I think anybody on the call would want to live to that age where you may have forgotten some of the things you did that were silly in your youth. So you can focus more on making more immediate memories. Now, all of these normal age-related changes are complicated at the point in time that you introduce any type of physical or cognitive disease. And so you see in the very last column there, the disease processes, and then you think to yourself, as you begin planning programs, how is it that these folks are going to be further impacted as I'm trying to make a difference for them in their mobility, with how they can be mobile despite vision problems and with any type of cognition issues. And I would be remiss if I did not thank the late Lois Ricci for the creation of this table. She was a giant in the field, a nurse for over 50 years, absolutely phenomenal human being. It was a complete tragedy to lose her last year, but this is the type of contribution that she made. And we're so grateful to have this sort of quick visual that is so easy to dive into a conversation from. So what I want to do is I want to take us into fall prevention, and then one example outside of fall prevention. And what we know about falls is that there are quite a few physical things that increase your risk of a fall. So muscle weakness, problems with your feet, a history of falls, problems with your vision, dizziness, which could come from medications, multiple medications, difficulty walking with balance. And then what happens when somebody falls? There is a fear of falling that is developed. And so when you are afraid of something, you tend to avoid it, right? Who wants to do a thing that you're afraid of? I'm afraid of heights. I try to avoid high places. It's a fairly natural phenomenon. But in that, you're perpetuating additional muscle weakness, additional foot problems, additional balance and strength issues. And because people see, right or wrong, that falls are a natural part of aging, they tend to accept this as a thing that they should maybe try to do something about. We know, of course, that falls are not a normal part of aging. And so getting folks past that and understanding that there is some amount of control that an individual can assert to make a difference in the risk of a fall is where we wind up landing. And people tend to be fairly receptive to that. Now, they're certainly more receptive to maybe doing some exercises while they're sitting down than they are about removing the rug from the kitchen, but they do understand why the rug in the kitchen would be an issue for them potentially falling. So we have to then begin to look at what other things we can do to incorporate something as benign as fall risk. And so we want to think about the other injuries that folks are at risk for and think about how we can reduce those. So certainly exercise and physical activity. If anyone could call exercise some other word besides exercise, I think we would all be very well off and it would be much more popular than it is. However, exercise and physical activity solve so many of the physical issues that people have. They also can introduce serotonin, which could help with some of the mental anguish that people have to manage. Chronic disease management, particularly here in the South, we're in the Rust Belt, we're in the heart disease belt, all those fried foods, which are amazing. However, they contribute to chronic disease. So if we're looking at exercising and physical activity, if we're looking at the management of chronic disease, which from a data perspective, as a whole, the population is continuing to improve on the management of those chronic diseases, which is why we're living longer. And in living longer, we have a longer period of time where we need to exercise and be physically active, where we need to have things to eat. Addressing nutrition and hunger is sort of a topic that people don't want to talk about. They don't want to admit that maybe they're having trouble getting food, that they are hungry. Certainly, we don't want to think about someone not being able to get a meal when there's food options seemingly all around. As you go down this list, it kind of goes from innocuous to more and more stigmatizing, right? Then you get into something like driver safety. Fairly certain everyone on this call is going to have something to say if I want to take your keys from you with no type of reason. We're very attached to our keys, and that attachment to your keys is what we're going to dive into in just a moment so you have a better understanding of what all of these types of things do to an individual as they continue to have physical and potentially emotional or cognitive declines. And then, of course, brain health. How can we talk about brain health when we hear about the brain is, you get Alzheimer's and dementia and then it's over, it's done, it's such a decline, you're removed from society. A person might have mild cognitive impairment and suddenly you don't hear from them anymore. It's wildly stigmatizing for the individual for so many reasons. And so we want to be able to talk about that topic when we're talking about things that are less stigmatizing, less scary for the individual. So this seems like a left turn, but hang in with me. When we talk about driver safety, the stigma is that older drivers crash a lot. Older drivers are hurt in crashes more often. Now, the data that you're seeing in front of you are for motor vehicle crashes, the mortality rate from 2013 to 2017. And certainly you see what the stigma might suggest, that folks over the age of 65 are more likely to die in a car crash. Now, the reality is that they're more likely to die in a car crash, but they're less likely to actually have a crash. The teenage and new drivers in that age range of 16 to 24 are the group that are most likely to have crashes in general. Now, the reason why we wind up having a driver over the age of 65 more likely to succumb and be a fatality in a crash is because of fragility and frailty. They're more likely to be injured, they're less likely to be able to recover from it. And so that really helps a person understand what's actually happening in those scenarios. The other piece that we have to understand is, why is it that we cling to our keys so much? So I'd like to challenge the group. How old were you when you got your first set of keys? Feel free to come off of mute or put it in the chat. See something in the chat. 16, great answer. Other answers? 16, 17, 16. Okay, yep. Thank you. In any given group, we're going to see a range from 15 if you're in like the rural areas, uh, all the way to 18 or even 20 if you're in places like New York, where walking is just where you go. Who wants to drive in that type of traffic? But your average is in that 16 years of age to 17 years of age. I would propose to you that we actually got our first set of keys much sooner than that, as toddlers. I wasn't talking about functional keys. Please don't feel slighted, but we got those keys when we were young, when we were maybe 12 months, 18 months old, helped with teething. Hopefully they didn't have sounds on them like this set of keys does. And you got to emulate mom and dad. You got to emulate the rest of your family. You got to be a grown-up. And then we always want to be a grown-up as we're growing, right? We want to do that next thing. And so when you get your first set of real keys, somewhere between the age of 15 and 20, 16 to 17 for this group, you probably remember what your first keychain was like. You probably remember what that felt like. How did it feel when you got your first set of keys to your car, to an apartment, to your first house, to an office at a job? You know, you feel freedom, you feel independence, you feel as though you are an adult and you can take on the world. Now, take all that away. It becomes a wildly tough conversation, because when you have those keys in your life, you're contributing to society. When you have those keys and you're going on to the next thing, you're moving forward in life. And suddenly, someone is saying to you, albeit from a good place, you should no longer be driving. I feel like maybe you shouldn't drive, with no actual observed reason for your driving skills. Now, if you're a bad driver at 30, assuming that by 30, most of us have gotten the wild out of our systems, at 80, you're still a bad driver. You're just slower, maybe with worse vision. But if at 30, you're a good driver, truly a good driver, being honest with yourself, at 80, you may be a little slower, yes, but you're still a good driver. That memory of 50 years of driving is something that generally stays with you. Now, that is, of course, barring any significant cognitive decline, any significant physical decline that would prevent you from being able to drive in a safe manner. However, where we're at is that in order to get to the place where someone's no longer driving, you have to understand their meaning of driving. You have to actually observe their driving skills. Do they have unexplained dings and dents in their car? Are they struggling? If we're thinking about other topics, think about understanding the meaning of a person's independence when we talk about brain health and dementia and Alzheimer's disease and your nutrition. People want to be independent, right? Now let's talk about not observed driving skills. Let's talk instead about their ability to contribute, their ability to finish a sentence, to grab the words that they need, to connect with others, right? If you're not observing those things, it might not be an issue. However, it's important to plan for those. And so what we want to do is we want to plan to have conversations, and we want to plan to introduce the concepts at a stage that's not an emergency. If you're caregiver, if you're a parent, grandparent, your parent, someone who maybe you think shouldn't be driving, someone who you think may be experiencing physical or cognitive decline, the time to have the conversation is not when they've had the fall. It's not when they've had the car crash. It's not when they've had a major outburst. It's before then. And the reason why we want to do that is so that we can have a person-centered approach where that person has the opportunity to maintain their dignity, to have a sense of control over what's going to happen. So, mom and dad, what would you do if you couldn't drive the car anymore? I'm going to tell you the initial reaction, friends, is to say, I would just die. Like, you're never taking my keys from me. That's what people say. So, why not have the conversation and talk about how you would feel? Or maybe, oh gosh, my car's going to be in the shop. I don't know how I'm going to get around. Oh, I found this great new app, Uber. Or, gosh, I've been struggling with memory lately. I wonder if maybe if I took some vitamins and talked to my doctor, that would help. Introducing the concept that there's a thing that you could do about it is part of this planning of these tough conversations. So when we don't plan for this, when we don't plan how we're going to be mobile, what we're going to run into is we're going to run into, quite frankly, exactly what happened in COVID. We are lonely. We are depressed. We are, frankly, bored. The quote unquote great thing about COVID is that our friends in the parks and rec industry never busier. Everybody was outdoor, trying to be away from everybody else, outdoor in the sunshine. But that's not typically what happens. Whether it's no longer driving, whether it's the shame and embarrassment, self-perceived of having a cognitive impairment, or not being able to feed yourself, or having the money to go out and get food so you then have energy to go out and do things. Planning for what you might do and knowing the resources becomes critically important, because this type of loneliness and depression and boredom and sadness, it is just as demanding and draining, and sets you up for bad outcomes as does the physical or cognitive impairment itself. So I want to switch up and talk a bit about dementia and Alzheimer's disease. This is one of the most stigmatizing topics we can talk about. And so one of the things that we did at the Department of Public Health, through support from the Alzheimer's Association, was to literally think about what we would do and what people need to know. And from that discussion, we came up with what is called the Think About It campaign. So what we did is there's a series of graphics, a series of fact sheets, a series of what we call Z cards, which I'll show you at the end so as not to disrupt the PowerPoint. And it is all about what happens if you get lost while you're walking or driving. Do you have problems with numbers or writing checks or paying bills? Do you have trouble doing the things that you normally do? Are you not connecting, or is a loved one not connecting either words or relationships the way that they used to do? And then to help people understand that doing all the normal things that we're told to do our whole life actually reduces your risk of dementia and Alzheimer's disease. It actually promotes brain health. So here are the graphics. This one is lost. And so this promotes a discussion about if you're, not remembering how you got home, which could be stress or it could be something else. If you got lost going to the grocery store that's 2 blocks over, it could be that you zoned out, but it could be something else. Are you having trouble paying bills and remembering due dates when you never had that issue before? These are the new cropping up issues. Are you having trouble connecting? Are you having trouble thinking of words? Surely in a presentation or a discussion where you're nervous, you might have that issue come up. But really, it's about that being a new issue and being able to connect with relationships. So what we want to do is we want folks to have these things in places where they normally go. And we also want to have it across topics, across mechanisms of injury and disease. So the CDC, they have a group in their chronic disease section called the Healthy Brain Initiative. And they came up with a heart health and brain health rack cards and fact sheets. This is a rack card. It can go in doctor's offices. This particular one is separate from the rest because it's fillable. You can actually insert your own logo from your organization in there, and you can insert a couple of other items that are specific to your state or local community or what have you. And so this creates a nice checklist for folks to consider their heart health. We talk a lot at the doctor's offices about blood pressure, about blood sugar, hypertension being a big killer of folks, particularly down here in the southern region. So we want to have, while we're talking about chronic disease management, to also be talking about our brain health. And CDC and their wisdom have come up with RAC cards for all sorts of them: diet, body, aging, blood pressure, injury prevention. There's one on wearing a helmet, which made me very happy, sleep, even hearing and blood sugar. And, you know, to be perfectly honest, hearing and vision and sleep and blood pressure, I'm sorry, not blood pressure, blood sugar, those are not things that are talked about as often. They're just things that you go to the doctor and find out about and have to take a medication. I'm going to take just a moment. I'm going to exit out of the PowerPoint because I want to show you. Can y'all still see my screen, or did it go blank? Can still see it. Okay. So on the CDC website, this is where you can get the customizable RAC card. And then I have to move. Here we go. Here is on the chronic disease website. Here is protect your head, protect your brain. It's a super simple card. It is about reducing your risk. So checking your home for hazards. You know, you're doing that, you're protecting your brain in a very environmental health kind of way, right? Super good. I'm going to scroll, pardon my scrolling. Healthy sleep. People don't realize the connection between good sleep and good health, and not just a healthy brain. Good sleep promotes better digestion. It promotes better everything. So you want to be doing that and have good sleep and a healthy brain. Healthy hearing equals a healthy brain. There's one on blood sugar, which for some reason doesn't want to download, and that's okay. Healthy blood pressure. This is blood pressure, hypertension down here in the South is really one of a really big killer. It goes hand in hand with heart health. You get hypertension, you wind up having heart issues or cardiac events, and it kind of gets out of hand very quickly. So to have that as an available item is really good. Also talking about having a healthy diet. It encourages you to have a healthy brain. So we're taking great public health messaging and we're turning it into messaging that can be seen for folks in their doctor's offices, out in their communities. They don't have to go in the doctor's offices, but they could. Another really important resource as we consider all sorts of stigmatizing topics or just regular topics that we encounter as professionals is the power of the area agencies on aging. No matter what state you are in this country, your state has area agencies on aging. Now, Georgia is a 159 county decentralized state, and so we have 12 area agencies on aging. There are other states that don't have quite as many, but they do have them laid out similarly to cover populations across their state. Here in Georgia, you can call and get referrals to information that are for your local community. They use certified information and referral specialists. You can go onto their website and get some resources. If you're really looking for warm handoffs, that connection from you or the caregiver to the person providing the service or the care for the patient, these area agencies on aging can help you do that. There's absolutely some wait times that can be had, just being fully transparent. However, even their online resources will connect you to what's available locally and get a person started on a path. And that becomes really important, that anybody doing any of these types of presentations, these types of outreach and engagement campaigns, that we get the people we're serving started on a path so that it is more engagement and less just outreach without talking to somebody. That's what I have for you today. I hope that it's helpful. We will absolutely be sharing the slides from today so that you have access to all of the different resources shared. I want to thank you for your time and turn it back over to Miss Emma.
Thank you, Liz. Great presentation. If anyone has any questions, please feel free to unmute or to write them in the chat. I kind of have a question, potential rambling question for you all about the effect of, for both of you, for the effect of stress on your brain and your brain health. Because that one slide you had, Liz, of the older adults in the rooms alone, and the stress and the isolation and the anxiety and all of that, how much does that, and since COVID, how much has that translated to more cases of Alzheimer's, more cases of unhealthy brains? Have we seen spikes like coming that way?
So no softball questions today. I love it. This is a tough and complex question. So we're going to break it down a little bit. So it's tougher to get to new incidents of dementia and Alzheimer's disease because it takes time to progress, right? So what we are seeing is we're seeing increases in the main contributing diseases that put you at a much higher risk for dementia and Alzheimer's disease. So stress equals higher blood pressure. Higher blood pressure is more strain on your heart and the other systems of your body. It equals less sleep. It equals eating differently because maybe you're queasing, you don't want to eat, right? And so those things compounded over time are what make them a known contributing factor for developing dementia and Alzheimer's disease. The trouble with dementia and Alzheimer's disease is that our only known causal risk factor is age. And it's not a great one. So we wind up having to go and think through all of the proxy type of risk factors. And we know that folks with more chronic diseases are more likely to develop dementia and Alzheimer's disease. We're also in a really interesting time right now because pharmaceutical interventions are coming down the pipeline with lightning speed. Not fast, really, but lightning speed compared to what they've ever done before, because there was nothing before. And so now there are a couple of options, and there are several more in the wings. And so with those pharmaceutical interventions, the need to have communities understand how connected their risk is to possibly developing dementia later on in life is really important. It's a huge opportunity for us to really get at prevention. And the science on that is going to be a little bit behind. And so it's not a direct answer to your question. And I would love to hear anything that Kamnisha might have to contribute as well, because I know that in the work that y'all do, you see a lot of things.
Yes, yes, I would say I kind of agree to your point, Liz. Like, we don't really know the effects of how COVID and stress have, if it's made things worse with traumatic brain injury or acquired brain injury. That's a good question. I don't know the answer to that question, but everything that you say, I totally agree with. Like, we just don't, we can look 5 years from now and see, yeah, there was a jump in motor vehicle accidents, or there was a jump in falls, or how the anxiety has, increased other parts of people getting better, from those injuries. So I don't have a question, but I will say stress overall and anxiety is huge, 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 huge with the healing process. And that's why behavioral health and the team as a whole, but getting moving, behavioral health, addressing certain things, not just for the patient, but for the family as well, is huge in someone's road to recovery with a brain injury, period, point blank. It really makes a difference. So yeah, I don't have a direct answer either, but I would say it would be interesting to see if there are studies that are run, from this time period now, maybe 10 years from now, and what the outcome was. It'd be good to see, if there's a change with that or a trend.
Thank you both. And I ask that because anecdotally, we always talk about in fall prevention, we talk about like the sandwich generation, right? We have our older parents who are aging, and we have our younger kids, and we find ourselves suddenly in charge of the family. Now we're the matriarchs and the patriarchs and all of that.
Yeah.
And in my own experience, my parents and my parents' friends have aged significantly. It's like they've super aged during COVID.
Yeah.
Whereas when it started, they might have been just retiring. And the isolation and the stress and the anxiety from COVID, I think can't be understated. And I think it's particularly telling in that age group, who all of a sudden are older, whereas they were just starting their like best years of their life, like retirement, all of this. And we see it in our kids who had to go through all of that too. So I think it's, as my mother would say, watch this space. I think anything that we do going forward in prevention, we have to do it now in a mindset of like the mental health piece always has to be there as we do our interventions, as we examine how they work, as we evaluate them. That is my my 2 cents on this piece. And I think both of your presentations highlighted that beautifully, that is a huge piece that we have to have forefront.
Absolutely. You raise an incredibly important point, and it goes back to my earlier bit about fragility and frailty. So if you think of stress and you think of isolation, and how much more susceptible they might be, just so like they would be for a physical thing, then their ability to recover from that is where we're at right now. And so we are in a space of where we are certainly talking about it in our different circles, watching it and preparing to see what it is that can be done, hoping that the great strides that are being made in interventions and in mental health can hopefully help bounce some people back. But that's so subjective. And just nearly impossible to pinpoint with any type of accuracy. Yeah.
Okay. If there's no further questions, this was an absolutely wonderful collaboration. Thank you both to both of our presenters. Happy Friday, and we will sign off here. Thanks so much, everyone, for joining us.
Happy Friday.